No, YouTube.
YouTube.
You'll do it from there. Okay. One and all. So this is Dr. Aparna this side, Clinical Director Neonatology and Consultant Neonatologist Pediatrician from KIMS Cuddles, Kondapur. We are very happy to meet you on today's session, which is going to be on the utility of chest X-rays in neonates. So over the next 45 to 50 minutes, we hope to sort of take you through some common indications for performing X-rays, a systematic approach for the interpretation of X-ray in newborns. And we shall be discussing a few abnormal X-ray findings with the specific context in neonatal respiratory and hemodynamic management. So what are the objectives of the session today? We shall be discussing about the few important clinical steps about how to perform an X-ray, when to perform, and more importantly, when not to perform X-rays, how to read X-rays systematically, and how to differentiate common respiratory morbidities based on the X-ray picture. We should also be discussing about how to identify some complications related to mechanical ventilation. So to begin, let us start by discussing how to perform the X-ray. The most important precaution that is to be always remembered is to not compromise on aseptic precautions. So with the principle of do no harm in newborns. So the X-ray plate as well as the linen that is used to cover the X-ray plate must be sterile. It is very important to not let the baby directly come in contact with a cold X-ray plate, which can lead to hypothermia. Very, very important not to interrupt the respiratory support or hemodynamic support or inotrops while performing the X-ray. So make sure that we do not end up with complications or accidents such as accidental extubation. The newborn safety is of utmost importance. We may sometimes have to remove the ECG leads or temperature probes for the interest of getting a better quality film and to prevent artifacts. But it is very important to ensure that the vital signs, at least the saturation and the heart rate, are being continuously monitored with a pulse oximeter if the baby happens to be a sick baby who is on respiratory support. Preferably, the infant should not be crying. So try to provide developmentally supportive care while performing the X-ray in order to get a good quality film. Take care to remove the ECG leads because this can often lead to confusion and artifacts while interpreting the X-ray. The feeding tube and oxygen tube, if present, must be ensured that they are lying on the side of the baby and do not cross the chest or the abdomen in order to avoid confusion. So the perfect way of positioning a newborn infant would be as shown in the figure here. So you can imagine the posture of an athlete after securing position in the match. So both the hands should be kind of positioned straight above the head, and likewise both the legs should also be extended and held by a person who is wearing a lead apron in order to get a perfect quality film. So this is the ideal way of stabilizing the newborn baby before the X-ray. Both the hands must be held above the plane of the body or on either side of the head, and both the legs should also be stabilized just below the hip. So coming to the ideal exposure for performing the X-ray, the ideal exposure or voltage, kilovolts and milliamps that are to be used by the technician who is performing the X-ray is mentioned here, 45 to 60 kVp and 0.5 to 2.5 milliamps. So this is the exposure that is usually used for getting a optimally exposed film or a well penetrated film, although this may vary from baby to baby. So if you find that for a particular newborn, the exposure was optimally visualized in a particular film, you may indicate so to the radiologist, the technician who came for performing the X-ray, so that the same settings can be noted down for subsequent films as well. It is useful to keep a record. Often the same one works well for that particular baby. So you can see an X-ray, an example here. So for commenting on the positioning, which we will be seeing in the subsequent films, we generally look at the medial ends of the clavicle. So as you can see, this is a badly positioned film. You can see that the baby's X-ray is rotated. The endotracheal tube is seemingly going towards one side, but in fact, it is because of the rotation of the X-ray that we are getting this image. You can see that the medial end of the clavicle on the right side and the left side are not equidistant from the vertebral column. And likewise, the distance of the vertebral bodies from the anterior ends of the ribs are also not the same. So this may lead to a difference in the exposure, and this can lead to a lot of confusion, particularly with interpretation of segmental collapses of the lung. And we may also get an image of the cardiac shadow being overtly pushed to one side or the other side. So we have discussed some aspects of the practical points to be remembered while performing an X-ray, such as how to position the infant, how to hold the infant for a non-rotated film. So we shall now discuss when to perform an X-ray, and more importantly, when not to perform an X-ray. So ideally, the right indications to perform an X-ray include an infant with respiratory distress. Now, how severe must the respiratory distress be in order to perform the X-ray? It is usually believed that distress which is at least moderate to severe at onset and is not improving over the period of time is something that indicates or something that demands an X-ray for evaluation. Likewise, even mild distress when persistent beyond 6 to 12 hours, we would still want an X-ray because we would like to rule out conditions other than transient tachypnea of newborn. So upfront moderate to severe distress, right from onset or right from birth or right from the time of admission and something which is not improving, or if there is mild respiratory distress which is persisting for more than 6 hours, 7 hours, still we would want an X-ray. Any respiratory distress that has a worsening course is also something that needs an X-ray to be performed. And new onset respiratory distress in an otherwise well infant. So if the infant was relatively well, but developed new onset or worsening respiratory distress, again, this is an indication to perform X-ray. Likewise, an X-ray may have to be performed in order to check the position of devices such as an endotracheal tube, chest tubes when placed freshly. When a baby has an accidental extubation, it is sufficient if you just note down the position at which the tube was earlier fixed, provided it was in right position. The same position, it can be refixed, and every time the infant is reintubated, a repeat X-ray is not indicated for checking the tube position. But the first time, it is ideal to get an X-ray for checking the position of the ET tube. Likewise, position of the intercostal drains, position of umbilical venous and arterial catheters need to be checked with an X-ray. Of course, immediate confirmation of these catheters, catheter tips, these days is often possible with a bedside ultrasound. Likewise, for the position of long lines such as peripherally inserted central catheters. Very important to also know when not to perform regular X-rays. An X-ray is definitely not to be performed as a daily ritual in a ventilated infant. So in every ventilated infant, provided the baby is clinically getting better or ventilatory requirement is getting better, it is not a daily ritual to repeat an X-ray. Also, X-ray need not be done for every dip in saturation. However, if there are persistent dips in saturation or repeated episodes of desaturation that necessitate increase in respiratory support, then a repeat X-ray is often useful. Likewise, X-ray is also routinely not indicated after every reintubation, as we already discussed. And if after extubation, the newborn seems to be doing fine and is clinically improving, and we don't see any worsening distress that may potentially lead to increase in the respiratory support, an X-ray is again not indicated. So there is also no role for regular routine X-ray, repeat X-rays after giving therapy such as surfactant replacement therapy. So these are all some indications, or rather contraindications, for performing an X-ray, which are often relevant to most of us in our clinical practice. So chest rays importantly complement our clinical diagnosis and are not to be used as a substitute for clinical diagnosis. Now, coming to how to read an X-ray. So rather than randomly going through different findings in the X-ray, it is often good to read the X-ray in a systematic fashion. So starting from commenting on the positioning, whether the X-ray is well positioned or whether it is rotated. How is the exposure or penetration? So this is the next thing that is to be commented. The type of X-ray, such as AP versus PA view, may also need to be mentioned while reading the X-ray. Often when it comes to newborns in the NICU, we are talking about AP views unless it is otherwise mentioned. The next thing that we comment upon is the soft tissue. So whether there is any significant abnormality that is noted in the soft tissue, such as subcutaneous emphysema, if there's significant edema. And then moving further down, we would comment on the bones, all the bones that can be visualized within that particular X-ray, the diaphragm, the position of the diaphragm and symmetry, the nature of the baby's lungs, particularly the expansion of the lungs and the parenchyma of the lungs, and other structures within the mediastinum. So this includes the cardiac shadow and the thymus. So let us start by discussing from the first point, that is the positioning. So how do we comment by looking at the X-ray, whether the X-ray is well positioned or adequately positioned, or whether it is rotated? So there are following things that are to be noted. So first and foremost, we comment on the position of the clavicles. So as you can see in this X-ray, while we can see that the right clavicle is fairly in line, the left clavicle is moving at a significant diagonal sort of line, at an oblique line. So obviously the position of the clavicles is not symmetrical. So this itself indicates that the infant is not well positioned. The second thing we look at is the distance of the lateral rib cage from the spine. So in this X-ray, if you look at the midline, which is the spine, and the distance of the lateral rib cage on either side, it looks as if the right lateral rib cage is closer to the spine in comparison to the left lateral rib cage. So this lack of symmetry again indicates the lack of appropriate positioning. Likewise, we can also look at the anterior ends of the spine, which you can appreciate here. The widened end or the oar-shaped anterior ends of the ribs also must be typically equidistant from the midline or the vertebral column. And usually, if X-ray is rotated towards one side, the ipsilateral lung looks more hyperlucent. So the presence of the asymmetrical positioning of the clavicles being more horizontal and slightly more oblique on either side, the presence of unequal distance of the lateral rib cage as well as anterior ends of the ribs from the spinal, from the vertebral bodies, as well as the presence of abnormal hyperlucency of the ipsilateral lung indicate rotation of the X-ray. So if none of these findings are present, we can say that the X-ray is well centered. Moving on to the next point, which is the exposure of an X-ray. So you can see two examples here. So the X-ray, which is on the viewer's left side, is an underexposed film where you can see that the most of the structures look unusually sort of more bright or more white, whereas a typically overexposed film tends to look more dark. So how do we comment whether exposure is optimal? So usually we comment on we look at the soft tissue in the X-ray. So ideally, if the X-ray is well exposed or optimally penetrated film, we will see that the soft tissue is just barely visible as a light whitish structure, and which is much less opaque when compared to the bone. And when we come to the retrocardiac vertebral bodies, they will be just prominent in an optimally exposed film. Now, if you look at the underexposed film, we can barely see the retrocardiac vertebral body, whereas this may look very prominent in this overexposed film. So ideally, in an optimally exposed film, the retrocardiac vertebral body are just visible and the soft tissue image is just visible. So if it is an overexposed film like the image on your right side, we barely see the soft tissue in the X-ray. So this again may lead to sort of missing pneumonia or patches of consolidation, especially when the film is overexposed. Whereas in an underexposed film, we may tend to overdiagnose pulmonary infiltrates. So the film in the center is an example of a reasonably well-exposed film. Now, the third aspect in our interpretation is the soft tissue. So the abnormalities that we may anticipate in the soft tissue may include the presence of edema or the presence of subcutaneous air, which can be sometimes seen if there is subcutaneous emphysema. So this is an example of an X-ray showing are not classically conforming to any one structure. So they seem to be extending beyond the thoracic into the abdominal cavity and likewise across the right side of the chest. So these are areas of subcutaneous emphysema. Likewise, this is an X-ray of a baby with non-immune hydrops and with edema. So we can see increased thickness of the soft tissue density. So this baby also has bilateral pleural effusion within the chest cage. And in addition, there is also increased thickness of the soft tissue density, which is indicative of subcutaneous edema as a part of anasarca, which is in turn part of non-immune hydrops. Now, moving on further, we comment on the bones, which can be seen in the X-ray. So usually in the chest X-ray, we will be able to visualize the ribs. In a AP film that is typically taken in the newborn, the posterior vertebral, the posterior ends of the ribs are more prominently visible, which are in attachment to the vertebral body. The anterior ends of the ribs would be kind of seen as oblique lines. And we would also be able to comment on the clavicles as well as the humeri in a routine chest X-ray. So ribs, clavicles, particularly for fracture, this is something that we should not be missing, and also for spinal anomalies. So this particular baby you can see has a thoracic hemivertebra. The other findings that we may be able to see would be osteopenia. So this is an X-ray of a baby wherein when we look at closely, we will be able to see that there is a fracture of the left clavicle. The next structure that we comment is the diaphragm. So diaphragm, we know, is the structure that separates the chest wall, the chest cage from the abdomen. And some of the abnormalities of the diaphragm that we can see in a chest X-ray include the abnormal tenting of the diaphragm as well as abnormal flattening of the diaphragm. So abnormal tenting of the diaphragm may be seen either with diaphragm being pulled up as a part of low lung volume, which can be seen in lung collapse or atelectasis. Likewise, abnormal flattening of the diaphragm may be seen with hyperinflation as a part of emphysema or with increased use of mean airway pressures in a ventilated baby. Likewise, while talking about the diaphragm, one also comments about the clarity of the costophrenic and the cardiophrenic angle. So costophrenic angle is an angle formed between the diaphragm and the lateral rib cage, whereas cardiophrenic angle is an angle formed between the cardiac border and the diaphragm. And lack of clarity of these two angles, the costophrenic and the cardiophrenic angle, can be seen in pleural effusion and pericardial effusion respectively. And as stated earlier, abnormal flattening as well as abnormal elevation of the diaphragm may be a significant abnormality. Abnormally elevated diaphragm, particularly if the difference in the position of the diaphragm on the both sides is more than 2 intercostal spaces, may also be a sign of diaphragmatic eventration. Now, after commenting on the first few aspects, which we have already discussed, which include the positioning, the exposure or penetration, soft tissue, bones, and the diaphragm. We now move on to the lungs or the pulmonary parenchyma. So what all are the aspects that we comment in the when it comes to the pulmonary shadow in a chest X-ray in a newborn particularly? So we comment on the presence of the expansion of the lung. So here we talk about three things: the normal expansion, low volume lungs, or the presence of hyperinflation. So typically the expansion of the lung is said to be normal if we visualize 6 intercostal spaces anteriorly and up to 8 intercostal places posteriorly. So this is a X-ray which where you can see the posterior intercostal spaces. So we start counting from the first rib here. So 1, 2, 3, 4, 5, 6, 7, and 8. So we see total 8 posterior intercostal spaces, which is considered to be normal in the newborn. If someone wants to count with the anterior intercostal spaces, so which is the space between the first and the second rib anteriorly, would be counted as the first anterior intercostal space. Then we usually expect 6 anterior intercostal spaces. More conventionally, we count the posterior intercostal spaces. So anything more than 8 posterior intercostal spaces is considered to be hyperinflation in neonates. If we see less than 6 posterior intercostal spaces, on the other hand, it is taken as underinflation or low volume lungs, which is an important sign of RTS. So we can see 2 examples here, one of underinflation of the X-ray on the left side, where if we start counting from the first posterior rib, we see 1, 2, 3, 4, 5, 6, probably 6 to 6.5 posterior spaces. Again, the diaphragm border is not very clear because of the presence of near whiteout lungs. So the pulmonary parenchyma is also fairly opaque in this X-ray. Most likely this baby has RDS. However, it looks like the baby has around 6 posterior intercostal spaces. Definitely on eyeballing, this looks like an underinflated film. And if it is less than 6 intercostal spaces, clearly it qualifies for underinflation, whereas anything more than 8 posterior intercostal spaces is taken as hyperinflation. While the baby is on high frequency oscillation ventilation, we consider that up to 9 posterior intercostal spaces is taken as normal. So how to look for expansion? As we just discussed, we take the first posterior rib to start with. The space below the first rib is taken as the first posterior intercostal space. So doing likewise, we count the intercostal spaces. So in this example, the first, second, third, fourth, fifth, sixth, seventh, eighth space, and the diaphragm appears to lie at between the 8th and the 9th rib. Now, coming to the lung parenchyma. So when it comes to the parenchyma, we comment on the nature of opacities, if opacities are present, and the presence of lucencies, if they are present. So anything which appears white on the traditional X-ray is taken as an opacity, and whatever is dark is taken as a lucency. So let us look at some common problems or abnormalities that we often see in the pulmonary parenchyma. The abnormalities that we look for are the presence of the horizontal and the oblique fissure. So often the presence of horizontal and oblique fissure indicate the presence of increased lymphatic fluid that is identifiable in the lung, usually seen with transient tachypnea of newborn. It may be also seen with pulmonary venous hypertension or pulmonary edema, or it can be seen in some cardiac conditions which can lead to pulmonary venous hypertension like obstructive TAPVC. We also comment on the hilum. Hilum is the region just outside the cardiac border. The presence of increased perihilar vascular markings can also be a sign of transient tachypnea of newborn. We also can comment on the vascular markings in the rest of the pulmonary parenchyma. Shows prominent perihilar infiltrates and the presence of a horizontal fissure, which you can identify. It is marked with a black arrow here. This is typically a sign of a baby with transient tachypnea of newborn having sunburst appearance. Whereas the X-ray on the right actually shows a newborn with coarse and inhomogeneous opacities that are distributed across the lung on both the sides. The lucencies, the opacities appear to be quite dense and quite opaque. These are interspersed with areas of relatively normal looking parenchyma, but it does appear that the newborn has hyperinflation on eyeballing, and this most likely fits with the diagnosis of Meconium aspiration syndrome. When it comes to the mediastinum, one also comments on the appearance of the thymus. Now, the thymus is identifiable with some classical named signs such as the notch sign, the sail sign, and the wavy thymus sign. So we'll look at this illustration to identify some of these name signs better. So when we look at the right border of the thymus, we may often see the sail sign, which resembles the sail of a ship. The notch sign, particularly, which can be appreciated at the right inferior aspect of the thymus, which gives us the appearance of a notch. The left border of the thymus often appears to have a number of wavy undulations, often called as the undulating wave sign, and it may indent with a sharp angle, an obtuse angle at the level of the cardiac silhouette, and this is called as the indentation sign. So this is an example of the indentation sign where the thymus forms an indent with the cardiac silhouette. And we may be able to see the notch sign and the sail sign often on the right side. So this is an example of the notch sign, which can be seen quite classically. So thymus can often be a confounder and can be often mistaken for cardiomegaly. So if we see that there is an abnormal kind of prominence of the superior mediastinum, it may often be wise to actually confirm whether this is a thymic shadow by looking at a lateral X-ray, or one may alternatively ask for an ultrasound of the neck. In very confusing cases, we may sometimes need to even do a CT chest for kind of differentiating between the thymic shadow and other possible mediastinal masses. So it can become a major confounder. When it comes to the cardiac shadow per se, as neonatologists and pediatricians, we are all quite fond of the cardiothoracic ratio or the CT ratio. So how does one calculate the CT ratio? Now, the CT ratio is calculated by dividing the maximum cardiac dimension divided by the maximum intrathoracic dimension. So in this particular figure, the dimension A, which represents the maximum dimension of the thoracic cage, measured from the prominent most point on the right and the left side of the rib cage, is taken as dimension A. This is taken as the denominator. And in the numerator, we take the sum total of the two lines which are drawn from the midline to the maximum point of the cardiac border on the right and the left side. So these are represented by B and C. So if we add B plus C and divide it by A, we get the CT ratio. So typically the CT ratio is taken as normal in a newborn if it is up to 0.60, whereas in adults or in pediatric age group, a CT ratio which is more than 0.50 may be taken as suggestive of cardiomegaly. Some normal variations in newborn infants are that the ribs may appear to be less oblique and they may appear to be more horizontal. The lungs may normally appear to be more hyperlucent when compared to a bigger child or an adult. We may normally be able to see air bronchograms visualized until the second generation bronchi, which may not be the case with bigger kids. Thymus can serve as a major confounder and can often be confused with cardiomegaly or enlargement of other potential masses in the superior mediastinum. And we may normally be able to see up to 6 anterior intercostal spaces and up to 8 posterior intercostal spaces. So these are some physiological variations in the newborn, and this need not be taken as abnormalities. Some other normal variations are the presence of skin folds, which should not be misinterpreted as pneumothorax. So if you can see in this particular X-ray, there is a line that appears to demarcate an area of opacity from an area of relative lucency that is seen in the lower part of the right chest. But if you look closely, this line is extending from across the chest to the abdomen, and this is in reality caused because of a skin fold, and this should not be misinterpreted as pneumothorax. This can be differentiated because normal lung markings can be seen even on the side of the chest, which is lateral to this line. So I'll kind of discuss some examples to help us use the X-ray for appropriate identification of some of the common respiratory conditions in newborn, and we should also be discussing some abnormalities with regard to the cardiac shadow in the chest X-ray in newborns. So we'll discuss with an example. A newborn baby, a baby boy who was born at 33 plus 6 weeks of gestational age by normal delivery to a primary mother with gestational diabetes is referred for respiratory distress. The mother's antenatal steroid status of premature rupture of membranes, or the duration of rupture of membranes is not known. There is also no history provided on whether there was meconium stain liquor or not. The newborn develops respiratory distress since birth and is referred at 4 hours of age. So the potential differential diagnosis in our minds as clinicians include transient tachypnea of newborn, Meconium aspiration syndrome, whether this is early onset sepsis with pneumonia, or whether this could be a respiratory hyaline membrane disease because this baby is preterm. So when we look at the approach and the various differential diagnosis, we will consider the risk factors, clinical course, which will help us to differentiate one from the other condition, and typical radiological features, all three of which help us to ultimately reach the most appropriate diagnosis in each of these conditions. So in RDS, the risk factors would include the presence of prematurity, usually less than 34 weeks, lack of antenatal steroids, either completely or giving incomplete antenatal steroids, being infant of a diabetic mother, either gestational or pre-existing diabetes, the presence of birth asphyxia requiring resuscitation, or RH immunization. So all these become risk factors which may predispose to RDS. RDS begins with respiratory distress, which may start soon or right at birth or just after birth, and can progressively worsen until around 48 hours of age, when the endogenous surfactant production will generally set in, and then starts becoming static and begins to improve later. FiO2 requirement can often go up to more than 40%, particularly when surfactant is not readily available or is not used. And surfactant therapy, which is being used more and more often and more aggressively these days, is something that reduces or kind of modifies the typical course and drastically can bring down the FiO2 and the pressure requirement. So we shall discuss the radiological features in a minute of RDS. When it comes to TTN, the typical risk factors would be a baby who is born either late preterm, that is between 34 plus 0 to 36 plus 6 weeks of gestational age, or a term neonate, usually born by elective cesarean section without a trial of labor, and mothers with diabetes. Again, in TTN like RDS, the onset of distress would be right at birth or soon after birth within the first 10 to 15 minutes, with maximum severity of distress being observed right at birth and the respiratory distress gradually improving with time. FiO2 requirement seldom crosses 40%. Again, we'll discuss the radiological features of TTNB in the coming slides. In a newborn with early onset sepsis or pneumonia, the risk factors could be the presence of maternal factors like prolonged rupture of membranes, clinical chorioamnionitis characterized by maternal fever, which is either more than 39 degrees Celsius, even one occasion, or 2 or more spikes between 38 to 39 degrees Celsius, history of multiple unclean vaginal examinations, and respiratory distress with onset right at birth or delayed and failing to improve with oxygen or CPAP. And again, we'll discuss the radiological features in a minute. Whereas when it comes to MAS, Meconium aspiration syndrome, the risk factors who is born through meconium-stained amniotic fluid, either term or post-term, with onset of distress right at birth or delayed onset of distress, meconium staining of cord and skin, and the presence of hyperinflated chest. So let's begin with transient tachypnea of newborn. So this X-ray illustrates some of the common findings of TTNB. If you can appreciate here, the newborn's X-ray is usually hyperinflated. There is presence of perihilar streakiness or opacities which are in the perihilar region, usually defining the vascular, the vessels, the perihilar vessels that become prominent. So perihilar streakiness with hyperinflation, with or without mild cardiomegaly, and with or without fluid which is visualized or prominently seen within the horizontal or oblique fissures is usually characteristic of TTNB. So normal or increased lung volume, presence of perihilar streaking, fluid-filled interlobar fissures, and mild cardiomegaly may be some of the common features. We often use the term sunburst appearance, where it may appear that the cardiac shadow is like the sun and the perihilar streaks may look like the rays of the sun. So this is a typical name that is used to describe the X-ray of a newborn with TTNB. These are some more X-rays, which again illustrate the presence of perihilar streaks that are present. In the first film, it may be kind of difficult to differentiate from RDS, especially if you see the left upper lobe. There is also the presence of some reticular lucencies, which may indicate that the baby also has a component of HMD. So this may be very often overlapping, because we may find that some late preterm babies or early term newborns may have an overlap between RDS and TTNB. The X-ray may of course be absolutely normal also in some cases of TTNB. Now, when it comes to RDS or hyaline membrane disease, the typical radiological findings include the presence of low volume lungs, the presence of reticulogranular pattern. So what do we mean by reticulogranular pattern? So this is a pattern of fine white opacities, which are the granular opacities, or a background of black reticulae or black lines, or a net-like pattern of black lines. So wherein these white opacities indicate hyaline membrane filled opaque alveoli, which are set against the pattern of the black lines, which represents the air-filled terminal bronchioles. The air-filled terminal bronchioles may appear prominent because of the collapse of the distal parts of the bronchiole, which may be occluded by the hyaline membranes. The presence of ER bronchograms beyond the second portion, that is, if you have to divide the pulmonary parenchyma from medial to lateral aspect into 1/3, 2/3, and last third, the presence of ER bronchograms beyond the second third or extending into the lateral 1/3 of the lung is also indicative of RDS. And of course, in the last stage, RDS may present with a ground glass uniform whiteout kind of pattern. So this is a reticulogranularity in more close-up orientation. So where we can see small white opaque granular spots which are interspersed in a background of white net-like black lines, which indicate the reticularity of the terminal bronchioles. Of course, in late stages, RDS, which often is accompanied by a component of pulmonary venous hypertension or edema, hemorrhagic edema, may just present with whiteout lungs, as can be seen in these two X-rays. Meconium aspiration syndrome, which is suspected in a newborn who is born through meconium stained liquor, typically term or post-term, and who may clinically present with severe respiratory distress, either from birth or sometimes slightly delayed starting a few minutes after the birth. Can present with significant tachypnea, the presence of retractions which may be variable, and may or may not be accompanied by hyperinflated chest or increased in the anteroposterior dimension. This is characterized by the presence of unilateral or lobar or segmental overinflation with the presence of coarse nodular opacities and patchy atelectasis with or without air leaks. So in contrast to the fine granular opacities of RDS, the nodular opacities of meconium aspiration syndrome may look quite coarse, and these may be accompanied by the presence of lobar or segmental hyperinflation. And sometimes we may also see the presence of air leaks even in the first X-ray. So this X-ray again is suggestive of meconium aspiration syndrome. There is bilateral, fairly inhomogeneous coarse opacities. They appear to be more prominent on the right upper and mid zones in comparison to the left lung. This is also interspersed with some areas of hyperinflation in the right lower zone of the right lung. So this is quite classical of the hyperinflated form of meconium aspiration syndrome, so as in the other X-ray, which is on our right side. Sometimes we may also find predominant atelectasis in a newborn with meconium aspiration syndrome. The most non-specific of the X-rays in the first few hours can be seen with early onset sepsis or pneumonia, where the newborn may present with diffuse opacities, which may be either symmetrical or asymmetrical, but typically not localized to one lobe. So it's very unusual to find lobar pneumonia in newborns. And pneumonia may also mimic TTNB by the presence of fluid in the horizontal fissure. So these are a couple of X-rays. This is a baby with pneumonia with asymmetrical or non-homogeneous infiltrates, which are seen predominantly over the right lung and more so in the right lower zone in the form of coarse opacities. This is another baby with pneumonia. X-rays are also used for identification of some of the misadventures with ventilation or complications with mechanical ventilation or with non-invasive ventilation such as CPAP. So some of these are the presence of hyperinflation of the lungs. So this is characterized by the hyperexpansion of the lungs indicated by the presence of more than 8 posterior intercostal spaces or the complete flattening of the diaphragm, or sometimes we may also see herniation of the lungs to the opposite side. We may also sometimes see pulmonary interstitial emphysema, which is the presence of air within the interstitial capillaries, interstitial spaces in the lung, and also in the perivascular spaces. This may be identified as thin reticula of blackish lines, which may be interspersed in the pulmonary parenchyma, and we may also see it in the perivascular zone. So these tend to mimic air bronchograms, although they may extend right into the lateral third of the lung, and they do not follow the typical branching pattern of air bronchograms. On the other hand, we may also find cystic pulmonary interstitial emphysema, which is characterized by small sort of blebs, cysts or blebs, and they may also take the tortuous configuration or tubular configuration, or they may look ovoid in shape, and these are translucencies representing air locules which are locked within the pulmonary parenchyma. We may sometimes see a honeycomb kind of pattern. So this is a typical pulmonary interstitial emphysema like pattern, where we can see that there is tortuous cystic translucencies that are extending into the lateral third of the lung, but they do not typically branch like a air bronchogram. So this is an indication of ventilator-induced lung injury, and this calls for reduction in the mean airway pressure, or we may consider using high-frequency oscillation if the baby is on relatively high pressures on conventional mode of ventilation. The other forms of air leak include pneumomediastinum. Now, pneumomediastinum can be typically identified by the, this is the angel wing bat sign. So this is characterized by the presence of air that is lifting the two sides of the thymus that can be typically appreciated on both these sides, indicated by the black arrows. So we identify the pneumomediastinum by presence of a radiolucent halo, which is situated around the cardiac shadow and is lifting the two lobes of the thymus, as seen here. This is also called as the spinnaker sail sign, or the bat wing, or the angel wing sign. So we may also be able to see the continuous diaphragm sign in some cases in pneumomediastinum because of the air underlying the lower part of the mediastinum. We may be able to see a picture as if the diaphragm is seen continuously. So this is called as continuous diaphragm sign. These are also examples of pneumomediastinum in both these images. On the other hand, in pneumoperitoneum, we may see air under the diaphragm, and there can be sufficient air sometimes which may lift the diaphragm, and we may see a uniform line which is outlying the right and the left lobe of the liver. So this is characteristic of pneumoperitoneum. On the other hand, pneumopericardium may be identifiable by the presence of a radiolucent halo. This is also seen around the heart, but in pneumopericardium, we almost always see air in the inferior surface of the heart. So this radiolucent halo will be also seen overlying the inferior surface of the heart. And it can be seen more clearly in the lateral view, wherein the radiolucency separates the heart from the sternum. So in pneumopericardium, the important differences from pneumomediastinum are: A, we don't classically see in the spinnaker sail or the angel wing sign, which is caused by the lifting up of the thymus in pneumomediastinum. And B, in pneumopericardium, we would see a radiolucent halo caused by air on the inferior surface of the heart. Now, pneumothorax is identifiable by the presence of increased translucency around the lungs and characterized by the absence of vascular markings and the presence of collapsed lung margin. So here is a classical example of a lateral pneumothorax, which is resulting in tension, and there is also significant mediastinal shift. You can appreciate that the area occupied by the air within the pleura is relatively is devoid of vascular markings or lung markings. We can also see the sharp margin of the collapsed right lung. We can also appreciate increased sharpness of the diaphragmatic sulcus here, which is called as a deep sulcus sign, which is also characteristic of pneumothorax, lateral pneumothorax. On the other hand, this baby in this X-ray shows a medial pneumothorax, which is identified by a well-defined mediastinal margin. Usually, we may not see the mediastinum margin this clearly. And anterior pneumothorax may only present with the lung looking relatively hyperlucent. When we look at the PA film, we may only see that one lung may be relatively more hyperlucent than the other lung, and this should have a high index of suspicion for the anterior pneumothorax. And we may also see a pseudomass, which is representative of the thymus. So a lateral view may be helpful in difficult to drain pneumothoraces. So this lateral view actually helps us to locate that there are pockets of air that can be delineated more anteriorly in the chest. So this is classically an anterior pneumothorax. Now, this is a newborn who presented with respiratory distress at around 3 weeks of age and was initially thought to have a bronchiolitis. But on repeated X-rays, it was found that the left upper lobe of the lung was persistently looking hyperlucent, and progressively this resulted in mediastinal shift to the opposite side, and this newborn actually turned out to have congenital lobar emphysema. So if you see a persistently hyperlucent lobe of the lung, particularly the commonly involved left upper lobe, then there is a high index of suspicion for congenital lobar emphysema. If in doubt, CT can help us in clinching the diagnosis. The characteristic features would be increased hyperlucency and the presence of herniation of the affected part of the lung, and there could be sometimes mediastinal shift as well. This is a newborn that presented with respiratory distress at birth, and there was an antenatal diagnosis made of CPAM. So CPAM is usually identifiable by the presence of multiple cystic lucencies, which are not communicating with the airway of the rest of the lung, and this is classical of cystic pulmonary adenomatoid malformation or CPAM. This is a newborn that presented with respiratory distress and scaphoid abdomen right from birth. And we can appreciate that there are multiple air-filled intestinal bowel loops that are herniating into the left hemithorax, causing mediastinal shift. We can see how the endotracheal tube as well as the feeding tube are pushed towards the right side, indicative of mediastinal shift, and the positioning of the stomach also being malposed. The contralateral lung is also significantly hypoplastic because of the cardiac shadow itself being displaced into the right side of the chest. So this is congenital diaphragmatic hernia involving the left side, the typical Bogdalek type of congenital diaphragmatic hernia. This newborn presented with excessive drooling of saliva and birth, and we can see how the feeding tube has stopped short at the level of around T2 to T3. So this is a classical case of esophageal atresia, and why we say this is atresia over tracheoesophageal fistula is because of the paucity of the stomach gas. Particularly if the X-ray is taken after around half an hour after birth, this paucity of the stomach gas when it should be present is actually indicative of a baby with esophageal atresia. This is a So this is an X-ray that is demonstrating the presence of the umbilical, arterial, and venous lines. This is one of the other reasons that we often do the X-ray. Now, usually an umbilical venous line tends to curve superiorly and lies to the right of the umbilical arterial line, and the position should be just at the level of the diaphragm or just below the diaphragm. The umbilical arterial line tends to curve inferiorly and then takes an upward course. This UAC is placed at a lower level. So the two acceptable positions of the umbilical arterial catheter are either the high UAC, which is said to be UAC tip lying between T6 to T9, and low UAC, which is typically supposed to be represented at L3 to L4. Both these are acceptable positions, but we try to avoid the position between T11 to L1 in order to avoid interference to the blood flow of some of the major branches of the abdomen aorta. The X-ray is also used for confirmation of the endotracheal tube position, which is again ideally supposed to lie between the lower border of the T1 vertebra until the upper border of T4. Preferably until the upper border of T3. So lower border of T1 to upper border of T3. So any undue depth of insertion of the endotracheal tube may result in selective ventilation of the right lung. So one can start counting the thoracic vertebra either by identifying the first posterior rib. So the first posterior rib that you can visualize here is usually connected to the T1 thoracic vertebra. So this is T1, T2, and this is T3. So this ET tube is lying exactly at the middle of the T3 vertebra. Likewise, this is the umbilical venous catheter, and this baby also has umbilical arterial catheter. So moving down, we can either count downwards from where we have started, from the rib that is connected to the first rib is connected to the T1. So hence this is T3, T4, T5, T6, T7, T8, T9 is where the position of the UVC is lying, and that's roughly corresponding to the position of the umbilical arterial catheter as well. So T6 to T9 is acceptable for UAC, and UVC usually we don't mention with the thoracic vertebra. We just say that at or just below the level of the diaphragm. Now, some abnormal cardiac conditions that can be identified with the chest X-ray. So this is a 2-month baby who is presenting with normal saturations with increased respiratory distress. So this typically is said to represent the figure of 8 appearance of supracardiac TAPVC. The baby on echo would have unobstructed pulmonary veins draining into the right atrium, causing right to left shunt across the AST. The saturations in all 4 chambers would be equal in this condition. This is a newborn who is 1 day old and had a structurally normal heart. And what we are seeing here is a prominent aortic knuckle. So this X-ray shows a newborn with a wall-to-wall kind of heart. So we can see that there is huge cardiomegaly, and the cardiac chamber seems to be enlarged and occupying the entire chest wall, extending from the right to the left side, and the CT ratio is approaching 100%. There are only few conditions that result in wall-to-wall heart. These include organic tricuspid valve abnormalities, including Epstein's anomaly, hydrops fetalis, birth asphyxia, pulmonary atresia, and with intact intraventricular septum, cardiac tumors, and pericardial collection, like a large pericardial tamponade or pericardial effusion. All of these can cause wall-to-wall heart. In a baby who is having borderline saturations and respiratory distress, intubated, requiring high pressure and high FaO2, and not improving with the usual ventilatory strategies, an X-ray like this with a reticular pattern is usually indicative of obstructed TAPVC. You can appreciate in both the X-rays that there is prominent pulmonary venous vascular prominence. This is indicative of pulmonary venous hypertension. There is a reticular pattern here. These are black lines interspersed with a white background. This is either seen in one of these 3 conditions: obstructive TAPVC or pulmonary venous obstruction of any other cause, like absent pulmonary veins. Or it may be seen in early onset sepsis pneumonia, usually caused by group B streptococcal infections, or with a classical hyaline membrane disease. The absence of cardiomegaly is one of the features again of obstructive TAPVC. This is a newborn that presented with cyanosis with borderline saturations ranging between 80 to 85%, and there was a short systolic murmur on evaluation. So this represents the classical egg-on-side appearance of the transposition of great arteries caused because of the narrowing of the apex. So this is egg-on-side or egg-on-string appearance. This is caused because of the parallel orientation of the aorta and the pulmonary artery, and this is classical of TG. This is a newborn who presented at 28 days with single ventricle and pulmonary stenosis and was started on prostaglandin infusion. The newborn developed swelling in the lower limb, and this baby was given prostaglandin infusion for a prolonged period. Noticing that there was swelling in the lower limb, X-ray of the leg was repeated, and so we can appreciate here that there is increased density of the cortex, the cortex of the long bones, and this is cortical hyperostosis, which is one of the classical complications of prostaglandin infusion. Some clues that we can get by looking at the tracheal sort of indentation. So the normal tracheal air shadow typically will either will typically curve on the right side. So there is a curve towards the right side, and this is representative of the left aortic arch, which is normal. So if you see the tracheal indentation with a curvature towards the right, this is typically representative of a left aortic arch. Whereas if we see that the tracheal indentation is either perfectly straight, or if it has curve towards the left, it is usually indicative of a right aortic arch. And a right aortic arch is usually seen in certain conditions such as truncus arteriosus and tetralogy of Fallot. So another shows we can appreciate that there is a midline liver. The liver is extending across the right and the left side. So a midline liver or the stomach on the right side, we can see how the feeding tube is going towards the right side. And this baby has hence situs ambiguous. There is also the presence of significant cardiomegaly and relatively oligemic lungs. So there is a simple rule of the thumb. If we see situs solidus with dextrocardia, 98% of the times this must be accompanied by complex heart disease. Whereas if you see situs inversus, that is if the abdominal, organs are inversed in position with levocardia, it is 100% of the times accompanied by complex congenital heart disease. So if we see situs solidus with dextrocardia or situs inversus with levocardia, it is usually accompanied by complex congenital heart disease. So these are some of the associations with right-sided aortic arch. So to conclude, some important take-home messages are: relevant clinical information is always essential for the interpretation of an X-ray. Perfect technique is essential for getting good and optimal films for optimal interpretation. A systematic approach for interpreting X-ray, starting from the positioning, centering, commenting on soft tissue, bones, the diaphragm, pulmonary parenchyma, and then progressing to the mediastinum, where we comment on the thymic shadow, cardiac shadow, will ensure that one doesn't miss any significant finding. So with this, I thank all of you for joining us today for this session of Cuddles Online Neonatology session. And we will be happy if there are any questions, if they can be posted in the chat box. Thank you all.